Hi, this is Brian Kim. I want to share with you this case of a patient who has a conjunctival and it turns out also a corneal pigmented lesion. And so I'm going to show you my technique on how I'm able to perform a no-touch technique in removing this pigmented lesion. This patient is a Caucasian patient who stated that he noticed this lesion growing over the last few years. So as a result, we decided to do an excisional biopsy of this lesion. As you can see, this patient has multiple foci of this pigmented lesion, and it's along the limbus here, and there's also some corneal haze in this area as well. And so we decided to go ahead and resect it. You can see I'm using an ink pen to get wide margins. And then I'm going to use a needle to inject 2% lidocaine with epinephrine. And I'm starting on the outside, and then I'm injecting and allowing the medicine to dissect the conjunctiva up and elevate the conjunctiva. And then I'm using a cotton tip to just massage the lidocaine with epinephrine. I'm going to apply some sponges soaked with alcohol over the cornea. And then try to resect this conjunctiva using some Westcott scissors, going around the area of the ink mark. And I'm cutting down to the tenons as well, and down to bare sclera. Doing some sharp and blunt dissection. And a wide margin is appropriate in this situation since the conjunctiva has some level of redundancy here. I'm using a cotton tip which also helps absorb the blood as I'm trying to bluntly and sharply dissect the conjunctinons off the sclera. In order to get complete resection of the tissue off the sclera, now I'm using a crescent blade. And using this tangential force technique, I'm able to essentially scrape the conjunctinons off the bare sclera, which is a similar technique I use when I remove pterygia on the cornea for my pterygium cases. As you can see, there's no underlying pigmentation that's penetrated into the sclera. And this is rather tedious doing it this way, but I have great control and I'm very carefully and methodically, again, scraping all that tissue off the bare sclera and pushing it up against the limbus. And as I do this, you can feel that the tissue is still adherent into the cornea as I start to push upward into the corneal tissue. And so this is actually pulling off and reflecting some of the superficial corneal tissue here. So I reflected it back down just to be able to see the extent of my dissection. And again, I'm applying some downward force just to make sure I scrape any tenons that's attached to the sclera here and bluntly pushing into the cornea. I think it helps when you have experience performing trabs and scleral windows and when you're doing like glued IOL or when you're doing M6 cases and being comfortable in manipulating and cutting on the sclera. So I go ahead and amputate that reflected conjunctiva, tenons, anterior corneal tissue there. And we're going to put it on some Tefla here, just to keep its orientation for the pathologist to evaluate. All right, that's the specimen. Because I applied the alcohol-soaked sponges over the cornea, I go ahead and scrape off the corneal epithelium over that same area, which is in the same quadrant of the pigmented conjunctiva and corneal lesion. Now, as I scrape here, you can see there's a small pigmented lesion right there next to that scar tissue. So I'm going to go back to it. I'm going to go ahead and do some cautery, just some gentle cautery to help my view and to dry the area. And then I'm applying some mitomycin over that spot, and I'm going to apply it under the cut edges of the conjunctiva underneath tenons, around the areas of the cut edges. So again, I applied some alcohol on the cornea to denude the epithelium and to kill any epithelium in the area of the pigmented lesion, and then mitomycin under the cut edges of the conjunctinons. Go ahead and apply it for a few minutes and then remove it and then irrigate the eye. And now I'm going to do a anterior lamellar keratectomy here with the crescent blade. I'm going to make a diamond-shaped area that I've marked off, going partial thickness. And then no different from when you're making a trap, scleral flap, or when you're doing a M6 case and you want to tunnel through the sclera. I think those skills are really quite important and vital to being a well-rounded and experienced anterior segment surgeon by doing these variety of cases. And so because of that, I'm able to perform this, again, lamellar keratectomy. I get under it, undermine it. And again, it's rather superficial. This is just anterior stromal. You can see how thin the tissue is that I'm undermining. And then I go ahead with Van Ness scissors and try to cut the edges in the attempt to lift that specimen off the cornea. And then using some forceps to help remove the remainder of that specimen off the cornea. So now it's off. You can see the base that's remaining is free of any pigmentation. I go ahead and place the specimen on some Telfa, and then go ahead and close the defect using an adovacal suture in a mattress fashion, and then running the suture to close the remainder of the conj and tenons. I'll show this part in higher speed simply because watching suturing is not the most exciting thing to see, but as you can see, there's good reapproximation of the conjunctiva covering over the defect. I try to do the best I can to try to cover over the keratectomy side as well, and then I'll go ahead and run the suture and close the conjunctiva, and that's the end of the case. Thankfully, this patient's pathology report did come back as a nevus, and it was not a melanoma, and so the patient did quite well, is healing well, and even though it wasn't a cancer, at least we performed a technique in such a way that it was a wide margin, no touch technique, and you saw the application of alcohol on the cornea, mitomycin on the cut edges of the conj and tenons, and then finally a partial thickness corneal lamellar keratectomy with complete excision of the pigmented lesion. So I hope this was helpful to you, and I thank you for your attention.